Sir, this is 8 o'clock, sir. Shall we start the program, sir? Okay. So, welcome you all for our 53rd peculiar case series in renal transplant meeting, and we have been successfully running for the past 3 and 4 years. And this time we have two interesting case presentations. Adoring this meeting is we have 3 eminent panelists, and one is Dr. Shishir Gang, and we are very much happy and honored to welcome you, sir. You are a seasoned and nephrologist, and you have trained a lot of DNB graduates, postgraduates, and you are recognized for your contribution in the field of nephrology in India. And sir is a chairman of Department of Nephrology at Mujibhai Patel Euro Nephrology Hospital at Nadiad. And he has over 25 years of experience in transplant, and he has produced a lot of research papers, and has been known for his soft-spoken skills, yet and wisdom in him is truly awesome. And he was trained in Arkansas Institute of Medical Sciences, Rock, US. And welcome you, sir, for this meeting. We very much appreciate you for your inputs and for the cases to come. Thank you for joining us.
Pleasure to be here on this meeting, and thanks for the invitation, and looking forward to a very interesting meet.
Thank you, sir. Joining him is Dr. Gopesh Kumar Modi. He is one of the senior nephrologist of his own center, Samarthan Super Specialty Clinic at Bhopal. He has over 20 years of nephrology experience, one of the earliest nephrologists of Bhopal. And I did my MD from Bhopal, and that time also I came to know about him, and he's one of the earliest nephrologists who started interventions in the nephrology, that is creating AV fistulas and other intervention procedures. He was known for his committed work at the BMHRC Hospital Bhopal before, and later he has started his own center. He's known for his academic skills, and his communication skills is awesome, and we are looking forward to you for your inputs for these cases to be presented.
Thank you, Raja, for good words. I'm looking forward to more learning than being a chair. So I'm really happy to be sharing the dais with Shishir. Thank you, everyone. And you described Shishir better than anyone else could have.
Thank you. And joining them is Dr. Vasudevan. He is an associate professor of nephrology at Madras Medical College, Chennai. And he's an alumni of Kilpatrick Medical College, and I did his DM there. And he's one of my contemporary. When I did my DM, he also did this DM from Kilpatrick Medical College. He's very sound in basics and very good transplant exposure. And he was very soft-spoken, but academically very sound. And his basics in nephrology is very strong, that you can appreciate from his case discussions. Welcome, Dr. Vasudevan, to this meet. And we have two speakers, that is Dr. Sriram Kabra is going to present the initial case, and he's a program director of nephrology from Marengo HCA Hospital, Faridabad. He has a vast experience from what he sees. He tells that he has more than 19 years of experience in nephrology and has done a lot of transplant, and I hope that he has a lot of transplant exposure, over 500 transplant credit. And he's a member of his various hospital committees over in his hospital, and he did his MD from Safdarjung Hospital, Delhi, and DNB from Pushpavati Singhania Research Center from Delhi. And hope we can find a lot of insights into this case to be presented. And the second speaker is Dr. Nithya from Apollo. He did her DNB from Apollo, and he's good. He has quite a lot of transplant exposure. I think she has a very good, interesting case to be shared for the next session. And welcome, Dr. Nithya, please. And Dr. Dharanya, her resident, is going to present the case, and she will be guiding her in her presentation. So, without wasting much of your time, we'll go on to the first case presentation with Dr. Sriram Kabra to present. Dr. Sriram Kabra, go ahead with your presentation.
Thank you, Dr. Rajarajan. I'm very happy and a little nervous and very excited to be here actually. And I look forward, rather than presenting, I look forward to a lot of learning from every one of you out here. I'll share my slides. I'll just take a minute. Okay, so I'm going to present. I hope my slides are visible.
Yeah, go ahead, please.
So just a second. Okay. So the first, I'll begin with the first case, and I'm going to present my experience of a living donor renal transplant who had a on-table rejection, and we had committed some mistakes during, managing this patient. But I'll be very forward to that, and I'll discuss how we manage, and we'll go for the discussion of this case. So this is a 32-year-old male. I don't know how to move this thing away from here. Yeah, okay. So this is a 32-year-old male who had a donation from his father. It's a living donation, 6/12 match. It was a ABO compatible transplant, O2O, and his basic native kidney disease was FSGS. He had been on hemodialysis for 3 months, initially via jugular catheter and then via AV fistula. And the only sensitization history I could get was one LDPRBC transfusion. That too, he got it at our place only because his hemoglobin was very, very low over the last 3 months. So this is his immunology, pre-transplant immunology. HLA is 6/12 match. He is CDC flow negative. We did a DSA cross match by Lysate just for the reason because the CDC flow was a bit old, and we thought we'll do it with a DSA Lysate before we go over a kidney transplant. The immunological risk we would grade as moderate because of the one LDPRBC transfusion, and he received very standard immunosuppression, ATG at the rate or rabbit ATG at the rate of 3 milligram per kg per total dose, methylprednisolone, and a triple drug immunosuppression, which is very standard. Now, what was the challenge? Surgically, in the OT, the donor had a massive visceral fat adhesion to the kidney, which was very, very difficult to dissect or separate from the graft as per the surgeon, and they were not able to separate it properly. So when they anastomosed this very kidney to the patient, initially, there was a brisk urine output of around 500 ml, and when they tried to close it, immediate on the closure, there was an anuria, possibly there was a kinking of the artery, and multiple attempts to close this graft failed due to drop in urine output every time. So after multiple episodes of closure, opening, they ultimately resorted to a graft reanastomosis at a higher level where they were able to accommodate the graft volume. However, immediately post-operatively, they had anuria. Intraoperative Doppler was done, which showed good flow till the hilum, but beyond the hilum, there was no flow. So it was an immediate catastrophe. Now, the crime committed was the intraoperative biopsy was not taken. This should have been done. Now, this was around 6-7 p.m. in the evening. The thing started in the morning and it ended till 6-7 p.m. He was shifted to the KT ICU with anuric state, and this is the Doppler. As I told you, there was no flow, demonstrable flow in the kidneys. And early post-operative differential diagnosis was kept as a severe acute tubular injury versus ischemic reperfusion injury versus hyperacute rejection or a vascular thrombosis. However, with the flow till the hilum, vascular thrombosis was unlikely, and we never considered this further in the differentials. On post-op day 0 at around 10 p.m. in the night after CBC, PT-INR, we did a kidney biopsy. There was anuria. A dialysis was done in view of hyperkalemia and slight fluid overload, and the ATG was continued at the prescribed dose on day 0, day 1, and day 2. Day 2, the third ATG dose was given, and on day 2 morning, we got a provisional biopsy report, which was around 36 hours post-operative, which showed an acute ABMR with some TMA. There was no comment made on C4D at that time. And after that, the DSA cross-match was sent. For day 1, we assumed that the patient possibly had acute tubular injury and DSA cross-match was not sent. And the patient was managed conservatively for day 1. However, on day 2 morning, it was a different revelation altogether. And so after this, a plasmapheresis was done, followed by IVIG, followed by rituximab. And then since there was a TMA in that, we counseled the family and we decided to go for eculizumab. A 900 milligram of eculizumab was given. And in the follow-up period, alternate day, the plasma exchange with IVIG was done, and followed by that, a 300 milligram of eculizumab was repeated after each plex. In the follow-up course, it was observed that the urine output gradually picked up, and there was no significant drain output. This is the biopsy finding on the of the kidney. And if I go by the Banff classification, it is a G1, PTC1, V1 with focal TMA and a negative C4D. So a diagnosis of acute active MVI, which is DSA and C4D negative, and which gave us a suspicion that possibly we may be dealing with a non-HLA antibody-mediated ABMR, along with a TMA was made. We received DSA on which was sent on day 2 on the next day, and the DSA antibodies were reported as negative. We also sent anti-MICA antibodies, anti-MICA antibodies comes as a package with PRA class 1 and class 2. All 3 were positive. So we were wondering, what are we dealing with? However, histologically, it was a microvascular injury, possibly complement mediated TMA and a hyperacute ABMR. Possibly. This is the investigation flow sheet. The only thing which is very significant out there is the fall in the platelet count and the continuous fall in the hemoglobin, possibly suggesting a TMA mediated injury. Vis-a-vis, this can be a thymoglobulin effect as well. And if you notice, the creatinine has been continuously on rise. However, on day 3 and day 4, the urine output started picking up. Actually, on day 4, the urine output started picking up. We got a Doppler done again, and it was a sigh of relief for us that the transplanted kidney showed some flow. Actually, the RI was very, very good, 0.6 and 0.56 at hilum and 0.6 at mid-segmental arteries. This is the only report I have available with me right now. And the follow-up investigations are as follows. The platelet count started rising. The hemoglobin continued to fall down. However, on day 4 evening, we started seeing a fall in creatinine, which continued for the coming days. And this is how the TAC level and the urine output has behaved. On day 1 post-transplant, day -1 post-transplant, pre-transplant, the TAC level was 10.2. Thinking that this was an acute tubular injury, we had stopped the tacrolimus dose, but the reinitiated on the next day, and that naturally the TAC level fell down, and on follow-up, the TAC level had gone a little bit up, which we had adjusted, and this is how the urine output flow has been. It has been continuously getting better. So coming to the management goals and the treatment which was given, the management goals, we all understand that we have to remove the circulating antibodies, we have to suppress the antibody production and block the complement activation since there is a TMA going on. And to do this, we do a pulse steroids, we do plasmapheresis IVIG, we give a rituximab, and then additionally, we decided since there was a TMA available and the eculizumab was also available, this was a case where it was a hyperacute rejection kind of a presentation. So we decided to give eculizumab in this patient. The rationale, we all understand. I'll not waste the time of the August audience with this rationale. However, just to reiterate that C5a and C5b will lead to a lot of inflammation, endothelial cell injury, and a lot of microvascular damages and TMAs secondary to that. The clinical response was there was a gradual increase in the urine output, the creatinine improved, and on day 10, we discharged this patient at 3 milligram per deciliter value with a constant urine output of 100 to 120 ml per hour. And the last follow-up of this patient shows the creatinine of 1.05. But this patient suffers from frequent UTI. The stent has been removed and has anemia. He also had the surgical wound dehiscence, which has been managed with VAC dressing, and it has been secondarily closed now, and he is fine from that perspective. However, this case rattled us, and some questions were raised which needs to be answered. One, why did the urine output stop immediately post-closure? Of course, it looks like repeated, ischemias and increased warm ischemia time has possibly led to acute endothelial injury. And there is possibly because of that, there is a early complement activation leading to all this histological conundrum, which we have already, highlighted: a microvascular injury, microvascular thrombosis, possibly an ABMR with some focal TMA. Question is, why did hyperacute rejection or the microvascular injury occur despite a negative cross-match, and the second DSA was also negative? DSA cross-match was also negative. Possibilities. One, it can be HLA, non-HLA associated antibodies, and this patient was demonstrated to be anti-MICA positive. However, I must commit to you that the way this patient responded to plasma exchange, it doesn't look like that anti-MICA positivity has led to this pathology, because MICA antibody positivity and rejection associated with this are not supposed to, get healed of so easily. However, we have used eculizumab, and whatever historical data is available to manage anti-MICA associated rejections are mostly based on the use of plasma exchange and IVIG for that. So this can still be a possibility. Complement activation independent of classical HLA DSA has occurred. However, ischemic reperfusion injury amplifying the endothelial exposure must have amplified the whole process. And there is, of course, always a possibility of undetected low-level DSAs, since both PRA class 1 and class 2 were positive post-renal transplant. However, again, the way this patient has behaved in last 2 months, he has done absolutely great, and we have not done anything extra apart from giving just 2 plasma exchanges and 3 doses of eculizumab. The only reason why we gave 2 more doses of eculizumab was that we had done a plasma exchange and we had to supplement the wash off of the eculizumab post plasma exchange. Next question is, why C4D was negative? Why there is a C4D negative ABMR? Possibly there is a complement activation which is below the detection threshold. There is a non-classical complement pathway activation, can be a possibility. Another possibility is a rapid complement consumption, and there is no time for a C4D formation to take place. And then, of course, there is a MVI phenotype, which we have already demonstrated in the biopsy. And we now recognize, as per the BAN 2022 update, that the DSA negative, C4D negative is supposed to be labeled as MVI phenotype, which has now come to our rescue, especially in this case. So what biopsy features favored MVI over or ABMR with MVI over ATN? There was glomerulitis, there was a peritubular capillaritis, there was intimal arteriitis, and a focal TMA with some interstitial hemorrhage, which definitely speaks that this is definitely not ATN, but ABMR. And why was TMA there in this case? Although it was focal, possibly it was a complement mediated endothelial injury, microvascular inflammation, and the usual conundrum of MAC membrane-associated complex formation, and which must have been triggered by some antibody antigen reaction. Possibly either there is an endothelial antibody which has been exposed by the ischemia, or there is an undetectable HLA antibody, HLA antigen to which the antibody has reacted and this TMA has occurred. We don't know as of now. These are all speculations. So what is the role of anti-MICA antibodies in any transplant or graft rejection? Just for the discussion sake, this is the target endothelial. This is an antibody to the target endothelial MICA antigens. Usually they are masked antigens. However, whenever there is ischemic reperfusion injury or there is acute tubular injury, these might get unmasked and the antibodies which are pre-existing may bind to them and then cause this whole cascade of rejection or microvascular injury. Then these are associated with ABMR, which is independent of HLA. We all know that. And the kind of injuries these anti-MICA antibodies, for that matter, any non-HLA antibodies they will lead to a severe kind of a rejection, which is usually not very amenable to only plasma exchange, or especially those angiotensin 1 receptor antibodies, especially those are very dangerous. We all know that. And important is the unexplained DSA negative rejection, which raises a suspicion of anti-MICA antibody.